Thank you very much to all the panelists, and if you could please come up and join us, Pat, Dr. Bemelman. Thank you for all the work that went into making these talks. It was amazing. So we have a few cases to discuss. We can start with case 2 right away because of time. Until we arrive there, since we have our European colleagues here, Pat, you're disturbing the panel. Pat, you're disturbing the panel. Dr. Bellman, have you moved on to really using no antibiotics as standard of care for uncomplicated diverticulitis?
You asked me?
Yes.
I was in the process of greeting.
Yes.
Okay.
Being disturbed by Pat.
Well, the PI of the Diabolo study is in my hospital, and she's chairing the guideline committee in the Netherlands. So I think that's the answer.
Yeah, sounds good. But you still listed it as a controversy.
Well, I listed it as a controversy. If you would have the voting in the Netherlands on this topic, there would be another result, I think, than yesterday at SAGES. And so that's why I'm saying it, stating it still as a controversy.
Yeah, well, we look forward also to the results coming in from the EAS.
Yeah. We did with the ECP in 2014 also a sort of guideline synopsis looking at where there was, among the guidelines, there was evidence or no evidence, and consensus and no consensus. And there are a lot of statements where there is evidence but no consensus among the guidelines. So I think this is one of these statements.
Certainly. Dr. Arezzo, have you moved on to no antibiotic therapy?
No, absolutely not. And I think that there is a really lack of evidence on that. That at least my opinion.
So we'll move on to operative diverticulitis for time's sake. Can we have the slides? These are not the slides. Okay, oh, there you go. All right, so a young male who's otherwise healthy presents to the emergency room with a 2-day history of worsening abdominal pain. Slightly tachycardic, febrile, has a localized rebound. So audience, we're gonna ask you to poll or raise your hands. So we're a quaint group right now. And then we'll ask our experts as well, fine-tune the questions for them. White count of 18 and a CRP of 160. This is snapshots of a CT scan, abscess, interloop abscess, free fluid, and free air. And he has localized tenderness. He's hemodynamically normal except for tachycardia of 110. He's making good urine output. So what would be your consent? Obviously, what you perform in the operating room depends on what you find. But with these findings, what would you consent the patient for? What would be your ultimate procedure for this patient? An open Hartmann's procedure, a laparoscopic Hartmann's, a laparoscopic resection with a covering stoma or not, or a lavage? Okay, we can move on. Oh, more answers. Oh, sorry, go back if more answers are coming in. We'll wait another few seconds.
Yeah, a little bit of free air.
Okay, have most of you answered? I see all the phones out.
None of these.
It's America. This is what we do in America. Hey, we're getting some interesting comments about why are we in the operating room.
Can I ask why do you want to operate this
It's
patient?
America, baby. This is what we do in America. Roll.
He has peritonitis.
Localized.
Localized. With a little fear. So how would you treat him, Dr. Arezzo?
In vain antibiotics.
Okay.
This will solve the problem in the vast majority. Never say 100% in our job, but in the vast majority of the patients.
Okay. We meant to describe a patient with Hinchy 3 that would have evolved anyway to purulent peritonitis.
But it's telling, right? You can't know who has Hinchy 3, and you can't know what's going to evolve. I mean, you have an abscess and a little free air. Unfortunately, the thing we have to go by is the physical exam and his clinical condition, right? And it's interesting that I don't think it's an accident that antibiotics are not on the list. I think that's part of the brainwashing of American surgery, actually.
Dr. Leroy.
Yeah, I've seen the proposal, but why you don't do percutaneous drainage It's 2.5 centimeter. It's
Oh,
the limit.
the patient had free fluid throughout the abdomen. Not only, there was no formed organized abscess, there was free fluid within the abdomen. Distant air, free fluid within the abdomen, and it wasn't a localized abscess.
Now it's getting
So,
better. Now
As
it's- now
Canadians,
you're-
we are a little slower to go to the operating
So I-
room is our
so I-
observation. And so we do treat a lot with percutaneous drainage, maybe more than our European colleagues, and a lot of IV antibiotics. But in general, we meant to present a patient, we went through the CT fast, but free fluid, distant air, and no localized abscess, to be clear.
Okay, so can I correct my observation then? Because in that only image, I couldn't see that free fluid down in the pelvis probably. Of course, we would operate that patient, but not because of the free air.
Yes.
We also stated in the consensus that free air doesn't mean anything. It depends on...
Agreed.
Okay, so free fluid is a different issue then. And then my idea would be to have a primary anastomosis here in this
Okay,
case.
To not do a laparoscopic
not
lavage, but to
lavage,
move on to a
not-
primary anastomosis.
Not lavage.
But
Okay.
I think it's important to emphasize, no matter what the scan looks like, it's really about what the patient's condition is. I mean, you get people with all sorts of gnarly-looking CT scans who, after a few liters of resuscitation and some antibiotics, actually look much better in 12 hours. So, even with that scan, I would be tempted to treat for a few hours to see if he got better.
With the caveat that they're not immunocompromised, right?
Right,
I mean, I
right,
think
yeah.
if they're immunocompromised, this patient's in the operating room.
Yeah, getting
Yeah,
a
truly,
heart
so you
rate.
can trust your exam.
Can I ask you to comment instead of another typical US philosophy to drain whatever you can, which is not the case in Europe, believe me, at least in Italy. What
Well,
does this
our
derive-
radiologists would not drain that. They would say it's too small, at around 2 centimeters. They usually are more attracted to larger looking collections.
Even when they are so easy to access, I mean, just below the fascia.
If you look at most of the data, it doesn't really show a difference when you are talking about abscesses that small. Usually the difference is when you start looking at larger things like greater than 4 centimeters or so.
All right, so let's just ask our panelists on this side how you would decide between a lavage and a primary resection.
Well, I think there's a clear indication for surgery. There is free fluid on a distance, so I think that's very important. And also, it would matter for me if the air would be subdiaphragmatic or whether the air is only around the bowel. I would like to have a good CT scan up front with rectal contrast. Most often I don't get that. And do a diagnostic laparoscopy. And nowadays, if I'm in doubt whether it's a Hinchey 3 or 4, I would ask the endoscopist to do a sigmoidoscopy during surgery, do a bubble test. If that's negative, there's no cancer, then I would lavage.
Okay,
I think it's one important thing. This is a relatively young guy.
Mm-hmm.
All the trials that have been done in Europe are on relatively fit patients who are not having inotropic agents. If you talk about lavage, it's about a subset of patients. It's not the patient who is under inotropics or had steroids or whatever. We have to realize that.
That's a really important point because I think many of the patients that we end up taking to the operating room might be on pressors, and so that's a very important distinction to make. And that's some of the comments I wanted to highlight from people who do a lot of laparoscopic lavage is exactly how you do it, whether you do an air leak test, so to say, because I know a lot of people in North America may not be doing that. So I think that's a very important point. How actively do you look for the opening? Because when I start looking, people tell me, well, you're going to stir it open and make the opening. Do you mobilize anything?
Well, it's in our study. We have discussed it quite a lot with Des Winter from Ireland, and he was in favor of not, let's say, taking down the inflammatory mass, leave the omentum there. I reoperated one of the failures, and what I noticed was that sometimes if the diverticulitis is on the top of the sigmoid, there's the big phlegmon is sitting as a cork on the pelvis, so you're not able to see what's behind.
Right.
And so on top of the phlegmon you have a purulent peritonitis, and then in the pelvis you have the stool. So I think you really have to see what's going on in in Douglas, whether it's not really Hinchy 4. So that's what I want to see, and I leave the Fleckman, I leave the omentum on the Fleckman.
I'm sorry, can you clarify that? Because if you leave the phlegmon, I'm not following.
I think
If
you don't mobilize the
if you-
omentum off the
I
phlegm.
don't take the omentum off the Fleckman, but I do want to, I would try to lift up the Fleckman from the pelvis, so I can have a look in the pelvis as well, if it's possible.
It's hard to do that if the omentum's not is socked in there, isn't it?
Well, it's on top mostly. Mostly it's on top of the sigmoid. It doesn't necessarily. It's adhered to the pelvis.
That's precisely the issue. I mean, the only video I've ever seen from a U.S. surgeon doing this with incredible skill is Morris Franklin, and he is extremely aggressive. He will take down that phlegmon and be prepared to suture close a defect if he can, even if there's actually a little bit of spillage, feculent peritonitis, as long as it's contained, like you'll find at the opening, he will try to lavage it, and he will suture it close. And his criteria for converting is if he cannot, if the defect is too big that he can't control it. But I mean, I've never seen any other, at least in the U.S., anybody be as aggressive as he is. So, but this is a magic sauce. This is really what distinguishes the master who can tackle that on and do this, from someone who's just not prepared to deal with a hole in the colon and suture it closed safely.
How often do the panelists suture the hole closed? So in my opinion, it's quite inflammatory. I don't know how sutures would hold very well in that. So on the side, suturing a hole closed, any experience?
I don't do that.
I don't do this operation, but if you're mobilizing, finding the hole, suturing it closed, why not just resect it and put it back together? Two healthy pieces of bowel.
Right. A lot more work, but I also don't feel comfortable suturing the hole closed.
We have to realize that the idea behind lavage is that it's a breakthrough of an abscess, which is otherwise sealed. So we should not mobilize the Fleckman too much, because you break the seal. But sometimes I encountered one patient, we could not include it in a trial because the patient was demented, an old man who was demented. And I scoped him, and he had the top of the Fleckman was sitting on the anterior abdominal wall on the bladder. So when we insufflated, it came down. And I saw a very small hole, and so I thought this guy cannot handle a stoma, because that obviously that was maybe the best operation for this old patient. So I sutured it, and I was lucky. But it's not the practice I would advise.
Okay, very awesome experience. We'll move on. So this patient had ileus and low-grade fever for the first 2 days. However, on the third day, he became truly sick, had generalized peritonitis, was tachycardic, was holding up his blood pressure and making good urine output by the time we went back to the operating room. And on diagnostic laparoscopy, he probably had the stool in the pelvis that hadn't been explored properly, and he had feculent peritonitis limited to the pelvis, and a clear hole in the sigmoid colon could be visible with fibrin. So to the audience, how would you proceed here? You have a scope in at this point. And he's hemodynamically normal. He's been resuscitated, and he hasn't dropped his blood pressure, isn't on inotropes. All right, so we're staying laparoscopic. It's pretty good. Some people are starting by a laparotomy, which is fine. This is the emergency setting if that's what you're comfortable with. Everybody is including a stoma. Nobody is doing a primary resection without a stoma in this patient. All right, so to this side of the panel, how do you decide if you're going to do a resection primary anastomosis, whether to include a covering stoma or not?
So first of all, in this case, I think this is the second look, right? So this is the take back. So the tissue is going to be awful, right? So ideally, if you're in this position, Hartmann's reversals are one of my least favorite operations to do. So if you actually can assess the tissues and get away with a sigmoid resection with a primary anastomosis and a diverting ileostomy, that would be ideal. I wouldn't do it unprotected. But in this case, my guess is it's going to be a mess. And I think laparoscopy is going to be really difficult. So I'd probably be sticking a scope in and then with a low threshold to convert to probably would be on Hartmann's, but I would at least give it a good college try to get a primary anastomosis together and protect it.
Dr. Flum.
So I just want to offer one point. I mean, I totally agree with that. I mean, the thing that influences me is that a lot of the research and evaluation we do is, I do in my group, is sort of like the real world, not what you all do or not what we say we do, but actually what people actually do. And about only 30% of people who have a Hartmann's and a stoma get reversed if they're over the age of 65. It's 1 in 3. We don't reverse enough Hartmann's, especially in this age group that we're talking that this often occurs in. And I just think we can't lie to ourselves and say they're equal procedures, and that's why I favor the protective stoma when the patient can tolerate it, just because I think we reverse ileostomies, probably in the 80%, 90% range. It's not 100% either, by the way.
Can I push back on that a little bit, though? I mean,
I love it.
I mean, I think there's two issues, right? There's the issue of what's appropriate to do in the emergency setting. So this is a patient who has already had one operation, and so you want to make sure that whatever you do the second time actually works, right? And sometimes if the tissues are going to be awful, that best thing is going to be a Hartmann procedure. But the second issue is learning how to reverse Hartmann's appropriately, right? So it could be that, like, we just don't reverse a lot of Hartmann's, but it may be just because that's difficult and we need to work harder to educate people on how to do that operation effectively, because it can be done. And you don't want to compromise the patient's health by doing an operation that's not necessarily safe in an acute setting.
Yeah, all good points.
May I point out a different thing? If the patient has stools in the pelvis now, probably the stools are going to be also in the colon. So it makes to me poor sense to have a loop ileostomy. And I'm surprised that you didn't consider here the washout procedure. So the question is the patient really stable? Because if the patient is stable, what I would do a washout and I would do primary anastomosis with covering it with an ileostomy. But if the patient is not stable, this will entail much more time and you'll not be able to do that. So you have to consider either just a Hartmann procedure or, as I said before, a damage control surgery procedure. But in any case, I would do laparoscopy only to confirm that there are free stools in the abdomen, and then I would convert immediately.
I really thank you for your comments. I have a hard time operating with energy sources in the midst of stool when we are doing a primary, or when we're doing a resection anyway. It just disturbs me a lot, and I end up converting at some point often. And the other point about a covering stoma with a colon loaded with stool, I'm interested. We don't do on-table lavage very often at my hospital, but that is a great way to go if the patient is stable. I think a lot of people do use the protective stoma in unprepped bowel, and I'm interested to hear from the other end of the panel how you do so and what you think of it.
Well, first of all, with respect to what to do, I completely agree with Jason. We have a failed lavage, so the second operation should be a success. We have the issue of if you do a primary anastomosis, what to do with the stool. Some people say that if you have a covering ileostomy that the stool won't move. The stool does move, I think. And if you have a leak, you will have a lot of stool coming out still. I'm not very fond of Hartmann, but why we are not fond on Hartmann's is that mostly the Hartmann is not closed because patients have associated incisional hernias, which are even a bigger operation than to repair that than to close the Hartmann. I did a couple of laparoscopic Hartmanns, and I was amazed how easy they are. You can close them. There is a lack of adhesions. You can do it single port or with a GT port, and it's very already competitive to closing an ileostomy. So in my practice, in a patient who is immunocompromised or is on pressures, I will do a laparoscopic Hartmann. In this case, where the patient has a second operation, I would do a laparoscopic Hartmann for many of the reasons the rest of the panel said already. But it's in the laparoscopy.
When you do a primary resection with anastomosis, when do you decide to do a covering stoma? Because the idea of doing a diverting loop ileostomy and unprepped bowel, to me, is, like Dr. Arezzo said, I'm not sure of the purpose. So I know in the studies, people were given the choice in some instances, and otherwise people crossed over and did what they wanted to do. So any other comments about that?
Well, it's difficult to say, but it's the gut feeling, I think. And otherwise, if patients has clear risk factors, then and you think your anastomosis will break down, then you would do a Hartmann. Yeah. And if you have if you think there's a risk, then you have to do an on-table lavage. We do that in the Netherlands, but nobody likes that. It's
Nor in Canada.
it takes additional time.
But I think there's also one other missing factor which we haven't touched on, which is the issue of bowel quality, right? So when you operate on a lot of these folks and they've been sick for a couple of days and they're miserable, and you get in there, the quality of the proximal bowel and the proximal rectum isn't so good. It's thickened. It's like cardboard. The thought of making an anastomosis and then just protecting it with an ileostomy doesn't really make much sense unless you're confident that that bowel is normal and will support anastomotic healing, right? So I think that's the most critical factor, whether you protect it or don't protect it. If the bowel quality isn't good, if it's dilated or lacks compliance, it's not going to work.
Yes, Dr.
No,
Leroy.
my problem is not asking what expert or expert center will do, or what we recommend for surgeons that are not expert in colorectal surgery, working in a small hospital, what they have to do. Because you see, this history is interesting because we know that we have to do the follow-up, very strict follow-up, when we decide to preserve, when we decide to do a lavage, and we can change our strategy, I will say, every day. But what we recommend when we have this type of case at the beginning to surgeon working in a small hospital. Do you recommend to do what we have seen, or immediately Hartmann procedures?
So that's an excellent point, and I think the take-home from all the literature is that there's pros and cons to each way, and there's no perfect way. The best way is to do what you're most comfortable with, what's safest, and what's going to require that the patient not need resources that are not available at your hospital. Know your hospital, know your skills, and at the end of the day, like many of you have said, we can reverse a Hartmann's if we have to. So a Hartmann's procedure still remains the safest procedure, and if the hospital or the surgeon doesn't have the skill or expertise, then I agree with you that we have to be careful. Dr. Bellman.
It's a message that is important.
You know, it's always, everyone always say a Hartmann procedure is the safest procedure, but a Hartmann procedure, a good Hartmann procedure, also an open Hartmann procedure, sometimes requires a little bit of mobilization of the flexure. Otherwise, you will have a retracted stoma. So you should not. I would not let do that. My, let's say, surgical trainee in his 4th year, 5th year on his own. Mm-hmm. So I would. You really have to realize it's a procedure which should be done properly.
Thank you very much. Thank you to the audience, and thank you to the panel for all the work and the excellent advice.